I am thrilled to be here with you all at the 25th National Forum. I started by looking back and thinking about 25 years ago, a small group of really committed, dedicated healthcare leaders began to get together, and they asked themselves the question, is quality good in healthcare? Is it excellent? Could it be better? And they began by exploring, by going outside of healthcare and looking to other industries. They looked to see, how do other people measure quality? How do they improve quality? How do they innovate? And they brought all those lessons back to us. And they basically started the movement that we see here today. This small group of really dedicated people started the quality movement by looking outside and bringing lessons in. They created the adage that we talk about all the time at IHI, all teach, all learn. And they brought lessons from everywhere to begin to help us to think, how do we improve healthcare quality? How do we measure? How do we innovate in healthcare quality? And in the last years, as Gary said, we've made so much progress. We've made patient care safer, we've made it more effective, more efficient, and certainly we've made it more patient-centered. So much has changed. We've basically had a collective impact, the theme of our forum this year. And you can feel it when you're walking through the halls here. We've started a global community of people who care so passionately about making healthcare better. But like all healthcare improvers, looking back gets us really impatient. I do think that we should stop for a moment and celebrate the progress we've made, and then we'll take a look forward. I began by going back over these 25 years and then thinking, what will healthcare look like 25 years from now, or maybe 5 years from now, given the accelerated pace of improvement? And I began to think, how do we improve when we're in such challenging times? Here in the United States, we're going through the rollout of the Affordable Care Act, and it's been a bit bumpy, but I've never felt more passionate about needing to live up to the goals of access and universal coverage. So many people are coming into the healthcare system now, and it's our job, I think, to make it the best system ever so that they can come in smoothly. And as I travel around the world, we all are suffering from financial constraints. We're all struggling with the burden of aging populations, increasing burden of chronic disease. So all of us here, regardless of the country we serve, we're struggling with the same kind of things, and it means to me that we need new models of care. As I talk to patients in different countries, what I hear is them saying, we need to have a collective impact. We together need to redesign healthcare. So, as the founders did 25 years ago, I've been going outside of healthcare to learn some lessons. Gary Kaplan has gone to Japan. Others have brought in Toyota production system and lean methods into healthcare. And so I've been looking out to try and figure out, are there lessons from other parts of our society that will help us to see what the vision should be? The profound changes that have been occurring in the past decade are the most recent developments, but I wonder how many of you have been following this amazing trend that I have been, called flipping the classroom. I've been looking to this principal in just outside of Detroit who decided to flip the classroom. He began by walking through the hallways of his school, and what he saw was teachers up at the front of the class giving lectures and then handing out homework assignments, and then he saw the students going home and struggling alone to try and learn. He was also a baseball coach, though, and so after school, when he'd be coaching his team, what he noticed was that he was doing something just the opposite. He would give all of the students video clips, and he'd say, tomorrow, this is the pitcher who's going to be pitching. So you watch the video, and then you'll know how to respond to this pitcher. And then when the team came together, they were practicing together. So he decided to try flipping the classroom. All of the teachers made videos of their lectures, and the students watched them at home or in the media lab at the school. And when they come into the classroom, they're working together. They're creating and collaborating, and the students are teaching each other as well as the teachers are having an amazing impact. What I love about flipping the classroom is the results. The students' grades flipped all the way across the school. Graduation rates rose to over 90%, and college attendance went from 63% to 80%. Most important to me, though, the lesson that I really took was that flipping the classroom closed the disparity gap. Those children from the most challenged socioeconomic families made the most progress, and the gap between the poorest and the wealthy closed, and that to me was a lesson about flipping healthcare. It also helped the teachers to identify what they used to call the silent failures. These were the kids that struggled because they didn't have enough food or they had no family support. And when they're sitting in the classroom, the teachers couldn't find them. But when they were working with them, engaged with them actively, they could find those silent failures. So the teachers love it. The teachers said they went from being the sage on the stage to the guide on the side. And they are getting more joy in work. So one of my mentors, Diana Chapman Walsh, the president emeritus of Wellesley College, she gave me recently a paper about MIT and the transitions that Massachusetts Institute of Technology has made. Now you can imagine that MIT has innovation in its DNA, but look at the transformation that this one organization has led. Back in 1861, MIT was founded, and the new president came on board, and he looked at the way that people were teaching in other colleges. It was rote memorization. It was sage on the stage. And he said, that's not the way we should be teaching. We should be teaching experientially. Basically, I think he was creating the first PDSA cycles, and he was saying, we've got to learn with our hands and our head together. In the 1930s, a new president came into MIT, and he brought a totally different perspective. He noticed that all the classes were organized by discipline. So you'd go into one class and learn from one professor, and then a totally different discipline in the next class. And he said, we can't afford to learn that way. We need to create multi-professional teams and cross-learn, cross-teach different disciplines. And I love that notion of multidisciplinaries back in the 1930s. In 1959, a new president came in. His transition was to say that they got thousands of applications every year and they took just a few. And he said, is that our job to create a few learned people, or is it our job to think in a very different way about how we influence and teach people? So he went from small numbers to saying we need to have a different way to teach and think so that we're teaching and educating the world. In '83, it went from classroom learning, where the teacher was the sage, to online librarians, to online tutors. The students began to teach each other. And then in 2011, the first MOOC came on, the first massive open online course. And what you saw then was that the MIT went from classes of 25 or 30 students to classes of over 2,000 people at a time. 1 year later, in 2012, the MOOCs went to 150,000 students. And then in 2013, I think a great transition happened where MIT went from saying, we compete with Harvard and all the other colleges around the country, around the world, to we need to collaborate. And together, if all of these colleges come together, there are now 29 colleges joined MIT, they're teaching more than 1 million students in every class through these MOOCs. So what you're seeing was the first 150 years, we saw amazing transformation, but the most important, I think, transformation in education came in the last 150 weeks. So what I'm asking for us to think about today is, how do we flip healthcare? How do we take lessons from the lean folks? How do we take lessons from education and begin to think in a very different way about how we give care with patients? I know that many of you are going to be out there tweeting. I know Jason Leach is probably already tweeting. But I want you to start to think, and perhaps think about tweeting what you will flip as we start thinking about flipping healthcare. So I went outside healthcare, and then I came back in, and I began to take a lesson. Tom Nolan's here, and Tom taught me one of the most important lessons of improvement. He said, care for the individual, but learn for the population. Care for the individual, but learn for the population. And so one of the things I love about this very simple framework is that it brought me to the patients. It brought me to the caregivers. And I asked several patients. I went out and interviewed some, and I'm going to introduce you to 3 patients this morning. But I asked them, where do you think healthcare is headed? And where do you think we should be headed? So the patients and the carers prompted me, as I was listening to them, to come back to think about the IHI triple aim. In all cases, they talked about health. Health was the first thing they talked about. So I was thinking about them as individuals, and then how do we learn for the population? But it is about health. And then secondly, the care experience. How do we make care better? And third, how do we bend the cost curve? How do we decrease per capita cost? So the patients on my journey all brought me back to the IHI triple aim, and I felt very encouraged that I think we're on the right track. One of the carers that I talked to is a friend, a family physician from Toronto. His name's Mike Evans. And Mike talked about flipping because Mike said he used to take care of his patients one by one. Many of them had chronic diseases, and he would give the same advice day after day to his patients. He said he really didn't feel like he was making as much of a difference as he could because he was spending all of his time trying to make it easier for his patients to do the right thing. So what Mike did was he flipped it, and he said, I think I'm going to make it harder. Watch Mike talk to his patients in a very different way.
Hi, I'm Dr. Mike Evans. Usually I'm talking about the science behind best health, but today I wanted to start a movement called Let's Make Our Day Harder. I know that sounds counterintuitive. In fact, usually I'm asking, how can I make it easier to do the right thing? But let me explain. A recent review in JAMA Internal Medicine compared the health of baby boomers to previous generations. It showed what you might expect. Medical advances have led to longer life expectancies. But it also shows something else. U.S. baby boomers have more chronic disease, more obesity, and lower self-rated health than members of the previous generation at the same age, even though we smoke less and work out more than the Mad Men generation. So what's the difference? Well, I think for a variety of reasons that include technology, culture, and attitudes, we have a severe generational case of sitting disease. We watch phones, tablets, and TVs. We stare at computers while we work and pride ourselves on not moving for 4 hours straight. We don't walk to a friend's house or a coworker's office. We text them. I text my kids in my own house. Don't get me wrong, I love technology. There's lots of good to be had, but I also think we need to be mindful that as technology becomes more ubiquitous, it can loot the medicine chest of our single best treatment for good health, being active, moving. We shop on the internet instead of walking to the store. We have vacuums that automatically circulate so we don't have to. Electric toothbrushes so we don't have to move our hands up and down. With the push of a button, we can manipulate the TV, the music, the temperature. We might even choose our house based on these conveniences or on the size of the TV room or garage, not walkability. Living further away gets you a bigger house, but it can also mean another half-hour a day of sitting in your car. To compare ourselves to the recent low-tech, simpler past, let's look at the Amish. The average Amish dude walks 18,000 steps a day. The average Amish woman, 15,000. American men walk 7,200 steps a day and women 5,200. In Canada, we're a bit better, and I actually find these numbers a bit high, but 2009 data show 9,500 steps per day for men and 8,400 for women. Unfortunately, this drops by about 1,500 steps a day once we hit 60. I think it's time to change our prevailing attitude. Maybe easier isn't really better after all. So how's about you and I start a movement, an anti-pushing the button so the door opens automatically for us movement. I'm not talking about extra stuff like going to the gym or running. If you do that, it's great. I'm talking about the health gold of our daily habits, what I call tweak the week. It's about looking at your week and seeing where you can make it harder by taking the stairs or riding your bike or getting off a stop early on your daily commute. Have a walking meeting instead of sitting in a conference room. I had a 90-year-old patient tell me the other day that he gets off 2 floors above his floor. When I asked him why, he said, well, I can't go up the stairs too well anymore, but I can still go down. Can you flip technology and use your phone or other wearable to monitor and remind you to move or stand more? How about going for a walk at lunch instead of just going somewhere else to sit? Can you reframe buying a push mower or a rake or a snow shovel as an opportunity? Instead of driving around the parking lot for 10 minutes trying to find that spot that's 10 feet closer, Can you just park farther away in that spot reserved for people who want to live longer and have a higher quality of life? Let's rethink this a bit. Let's you and I and our loved ones and our coworkers and our friends, let's all mix in a little low-tech into our high-tech. Let's do something that's totally in our control. Let's make our day harder.
So today, we're going to flip healthcare. I'm going to take you on a journey to meet the people I met and to give you a sense of the vision that these people have. If you've heard me talk in the past couple of years, you've heard me say this. The first flip I think we need is, as Susan Edgman-Levitan would say, from what's the matter, medicine, to what matters to you. I think that's the first flip. And the reason I think that this is so important is this flip informs all that we do. It's about how the person, not the disease, not the condition, but the person is at the center of improving health and healthcare. Dr. Laura Gottlieb wrote it perfectly, I think, in the San Francisco Chronicle. What she describes is this. She said, "I diagnosed abdominal pain when the real problem was hunger. I confused social issues with medical problems in other patients too. I mislabeled the hopelessness of long-term unemployment as depression and the poverty that causes patients to miss pills or appointments as non-compliance. In one older patient, I mistook the inability to read as dementia. My medical training had not prepared me for the ambush of social circumstances. The ambush of social circumstances. Real-life obstacles had an enormous impact on my patients' lives, but because I neither had the skills nor the resources for treating them, I ignored the social context of the disease altogether." I think what Dr. Gottlieb is doing here is telling us that we need to flip from focusing on the medical condition to focusing on the patient, to move from what's the matter to what matters to you, to move in the years to come from disease focus to health ease, and to really begin to think about health in a totally different way. So as we think about this now, I'll introduce you to the three patients who most influenced my thinking this morning. The first is Trevor Torres. Trevor taught me about what it's like to be a young person with a chronic disease. So here, meet Trevor.
Hi, I'm Trevor Torres. I have eczema, asthma, I suffer from sleep deprivation, I'm allergic to nuts, but the fun one is juvenile diabetes, or type 1 diabetes. I was diagnosed with diabetes probably like 2 years ago, and I used to describe myself as a professional diabetic, except the problem with that is I haven't figured out a way to get paid yet. So until I do that, I like to call myself a diabetes evangelist, because I would recommend type 1 diabetes to anyone, and I'll get to that in a second. Just to describe a little bit with my situation, I pretty much do everything on my own. I track my own blood sugar, give myself my own shots, calculate my meals and insulin, and I've pretty much memorized the carbohydrate content of like every food in my house just because of how much I use it. So it's kind of a fun party trick, like, oh, hey Trevor, how many carbs are in like this soda? I'm like, it's 42 for one can. And I would definitely recommend diabetes to everyone for two reasons, mainly, although there's a lot. I'm not going to list them all. One, it's so much easier to be healthier if you are a type 1 diabetic, because you're already looking at all the nutrition facts on your foods anyway. So I think that a lot of the diet problems people have is just because they kind of unconsciously eat something bad. They're like, oh, they look at their day or whatever, and they're like, oops, I probably shouldn't have eaten like that many cupcakes or something. And another thing I really like about diabetes, I feel like it makes me more confident. It's like, and this might be a little irrational, but it's like any accomplishment I have, I feel like it's that much cooler because I have diabetes. So I accomplished this thing, and I had diabetes at the same time. There's two main things. One, don't condescend. Especially for me, I don't really like that because I am one of the smarter patients, and so I guess I could have said stay out of my way, but that doesn't really help very much. When I was first diagnosed with diabetes, they were like, you can give yourself insulin in one of two ways. You can do it based on your blood sugar. If you have higher blood sugar, give yourself more insulin and so forth. Or you can do it based on what you're going to eat. You know, if you're going to eat X amount, give yourself X amount of insulin. And I was just like, well, that doesn't make sense. Why don't I just come up with an algorithm that incorporates both variables? So again, that's probably a little atypical, but if they already have something figured out, you don't necessarily need to lower the level of your explanation down to what you perceive your patient's level to be. You can explain something, and then if your patient doesn't understand it, they can ask, for clarification. Now that may be just me, but I really hate it when I feel like I'm being talked down to. And that also might be my age. I know we kids are a little upstart about that.
So Trevor's a millennial. Trevor is the patient of our future. And Trevor really wanted to be here today. He wanted to be up here on the stage with me teaching you himself, but it's finals week at the University of Michigan, so he had to decline. But I talked to Trevor on the phone a few weeks ago, and I said, Trevor, define health for me. How do you think about health? And he said, he's at college now, and he said his life is so unpredictable. He said, health is the energy to do all I need. He said, every day is different. And he said, for me, health is being able to predict my health so that I can deal with my unpredictable college life. Health is the energy that I need. So I said to Trevor, tell me about health care. When you go to get care from your physicians, tell me what is important to you. And the first thing he said was, it isn't my physician and me, it's my care team and me. He said, I don't only see one physician now, and he said, basically, I've flipped so that I have a whole team of people. But he told me what's important. The first thing he said is no surprises. Again, unpredictability in his life, he needs predictability in his health. He said, no surprises. He said, give me straight answers. I don't want you to talk down to me. And he said, give me easy access. He said his favorite thing is when he's not sure about something, he just wants to be able to pick up the phone and call his team and get an answer immediately. The idea of setting up an appointment and making a visit, that does not appeal to him. He would love FaceTime. I asked him about texting, and he said, I'm going to cut you old people some slack, which really, I don't know. But he said, I'm going to cut you old people some slack, and he said, we won't really feel like we need to text you all the time right now, but you really need to get ready for this. So he said, what I want is a strong bond between me and my care team. He said, I want the ability to express a concern and get my advice and my answers right away. He said, I'd love FaceTime visits, but he said, I'd love all of my care to happen without going to the office. Trevor knows what this is. How many of you here know what 5,000 hours is? Just a few. 5,000 hours is the number of waking hours in a year that Trevor has to take care of himself. So Trevor is taking care of himself for 5,000 hours. In the old days, he would see his doctor twice a year for 15 minutes. So should we optimize the 2 15-minute visits, or should we focus on the 5,000 hours? And Trevor believes that we need to flip care so that we're not only focused on the visit, but we're thinking, how do we optimize those 5,000 hours with relationships and with interactions that are frequent, short, direct, and helpful? No office visits, constant care. Beside Trevor, there are about 26 million people in the United States with diabetes. 8.3% of people here in the United States have diabetes, and those numbers are either close to or getting close to diabetics in other countries. So when you think about it, we've got a huge problem to solve. And again, going back to flipping the classroom, the thing that bothers me most is the disparities, the racial disparities in the rates of diabetes. If you think about it, an Asian American here has an 18% higher risk of becoming diabetic, 66% higher risk among Hispanic Americans, and 77% higher among African Americans. That is a gap we can close if we start thinking about flipping care. These complications are costly. Thank you. Come on. We've got to close these gaps. The complications are costly in human terms. They're costly in financial terms. They're costly in productivity terms. And so I really feel like if we flip care for Trevor, we can close the gap. For 26 million here in the United States, we can close that disparity gap. At Health Partners in Minnesota, they look at closing this gap in a very different and wonderful way. They show it on a slide, and if you look at this slide, on the right-hand side, you'll see the kind of medical view, where how many patients have their blood pressure controlled, or have their hemoglobin A1C in control. But on the left side is the human side. That's how many fewer heart attacks, how many eyes were saved, how much sight, how many limbs were saved. And I love this slide because it really does come back to Trevor's worry. How do I take the very best care of myself? How do I flip care? So let's close the gap for Trevor. We can prevent some kinds of diabetes, and we certainly can save Trevor and get him into a different place, get him comfortably at school. The second patient I met is Carola Eisenberg. Carola is a wonderful and very special lady. She's a physician from Argentina. She has a wonderful family, but she lives independently. And Carola is 96 years old. So I went and visited with Carola, and I asked Carola, when you think about health, what does health mean to you? And the first thing she said is, first, health is a human right. But I sense that's not what you're asking. But she had to tell me that. She said, health is a sense of well-being that enables me to contribute to society and to my community. She said, so much in society today needs fixing, and I want to help. If I'm in pain, then I can't contribute. I can't add that meaning to my life. So for Carola, health is being pain-free and being productive. It allows her to read, it allows her to call and go out into society and help. And she also described to me what she wants from health care. So I said to her, Carola, tell me about health care. And she said, I'm in love. She said, I have a new physician in my life. And so I said, tell me about this. And she began by going back to her old physician. She said that last year, now remember, Carola's 96, she's almost 97. And she said her physician set up 4 appointments for her in a week. She said that the first appointment was for a B12 shot, the second was for a physical, the third was to get lab work done, and the fourth was to get an X-ray. So as my friend Victor Montori from Mayo would say, the burden of the treatment exceeded the burden of the illness. And Carola called her doctor and said, can you just write a prescription for the B12 shot? I'm a doctor, I'm surrounded by doctors, I can have somebody give it to me at home. No, that's not how we do things. Can we combine the visits? But what happens is the clinical care was designed around the clinician's needs, not around Carola's needs. So Carola changed doctors and fell in love. Her new doctor is a geriatrician. He comes to visit her at her apartment 4 times a year for an hour and a half. And what he does, he brings a medical student to every visit, and she loves that she's teaching medical students again. But what he does when he comes to visit is he draws blood and he takes her vital signs, some of the normal things, but he's also assessing her gait. Is she stable on her feet? He's looking at her weight. He's looking at her nutritional status. He's assessing her surroundings. He's looking at her mood and her sense of spirit. He's looking at her health. He was there just before I visited her, and he wrote a prescription for something that I had never seen before. It was a different chair, because her chair was very, very low, and she'd walk over to it and she'd plop down. And he said, you're going to get hurt by plopping, so you need a higher chair. And that's the kind of a thing, I think, that makes Carola fall in love with her doctor, because he's not looking at her hemoglobin, he's not looking at her blood pressure, he's looking at her health. So he asks her 4 questions every time he visits. He says, what's worrying you? What are the 4 things you worry about as you get older? And the first thing Carola said is, I worry about slowly losing my independence, because being an important asset to society is so important to me. I worry about slowly losing my independence that I've fought so hard for. The second thing, she said, I worry about watching my friends die. The third thing, she said, is I'm really afraid of pain. And the fourth thing I loved, she said, is help me understand when I should stop going to the doctor. Like, I'm 96 years old. How many more visits to the dermatologist should I make? And how many more visits should I plan for my dentist? So Carolla is flipping care. She's saying, how do I stop going to these things? Because it really isn't adding meaning to my health. And her doctor, her love, calls her from time to time. And he just asks, how are you doing? How's your health? How's your family? And he really cares about her. I loved being with Carolla in her place and watching this 96-year-old, very amazing person going from a Rolodex to a computer. But this is the kind of thing that I think we need to flip. Carolla has flipped her own healthcare from the office to her home, from more visits to stopping them, from clinical indicators and chief complaints to health, and from hospitalizations to independence. Carolla is exceptional, but she's not alone. In the United States, there are 40 million adults who are over the age of 65. And I read a surprising statistic that says if you get to be 65 in the United States, you can expect to live another 18.5 years. So we've got this aging population, and life expectancy in the United States is shorter than it is in most parts of Europe, Singapore, New Zealand, Australia, Cuba, Hong Kong. So we've got, I think, a global challenge here, and I think the best thing we can do is flip care. Carolla's group, those people who are 85 and older, are the fastest growing group in our country. And almost half of women 75 years and older are living alone. So what we need to do is think about, what does health mean to them? 40% of those people, like Carolla, will rate their health as excellent or very good. But on average, they end up going to the doctor's office 7 times a year, and a third of them get hospitalized each year. So we need to flip care for Carolla. We need to coordinate all aspects of her health, her physical, her social, her functional, her emotional, and safety in her home. We can prevent hospitalizations, and we can save tons of money if we work with Carolla to flip care for her and for others. And the third patient I met I had the most fantastic visit recently to Boston Medical Center. And I sat in on a visit. It's called Centering Pregnancy. Centering Pregnancy, if you haven't heard about it, is flipped care for women who are pregnant. It was developed by Sharon Rising, a midwife, some years ago, and Sharon's here with us today. Let's try and find Sharon. She's a visionary who's helped me think about maternity care in a totally different way. So centering is a wonderful option. About 20% of the patients at Boston Medical now choose this option, but I predict an incredible surge in this going forward. A centering pregnancy method is different than normal care in that when you find out you're pregnant, you get 10 appointments, 2-hour appointments. So you have your whole pregnancy appointments planned out from the very early time. And all of your appointments are with other women who are about the same stage of pregnancy as you are. So you go to your visits, your maternity visits, with 10 or 12 other women who are all in the same situation. It is breathtaking. You don't go to registration, you don't sit in a waiting room, you don't go into an office with a physician by yourself. You walk into a wonderful room, and the room just buzzes. I mean, all the women are talking to each other. They're getting advice from one another. There's a nurse, midwife, there's a physician, and there's a medical technician in the room, but I'll tell you that all the care is happening between the patients. I went recently and said they have healthy food. Patients learn how to take care of themselves. So I went through the pregnancy visit with Nora, a patient, a young woman who's about 24 weeks pregnant, and her husband's back in Nigeria. He's hoping to make it to Boston for the birth of their baby. But I sat with Nora and I watched how these women learn how to take care of themselves. In centering, they go in, they take their own blood pressure, they weigh themselves, they do their urine specimens, they fill out the chart on how they're doing, and then they share the chart with the midwife and the physician. They're all in one room, they're having snacks, they're playing with their kids, and then there's a little bit of a back part of the exam room, the back part of the conference room where they go to get examined. They're all in the same room together. So I sat with Nora, and I was talking, and we were chatting with all the other women, and it came time for Nora to talk, and she said, "I am so scared." She said, "It's my first pregnancy," and she said, "I am terrible with pain." And she said, "I really fear I'm not going to be able to make it through labor." She said, "I can't sleep at night. I'm so afraid." So the midwife said, "Well, 3 of you have had babies before. Talk to Nora. What happened?" And one of the women said that, she said, "I wanted to have a natural childbirth for my first baby, and I did." She said, "I'm not going to pretend it didn't hurt. It was very, very painful. But what was important to me is that I have the baby naturally." The second woman said, "I ran to the door screaming, 'I need my epidural now.'" And she said, the only word that would come out of my mouth is epidural, epidural. And she said, "And I would highly recommend that." And so Nora was sitting there, and she was trying to figure out, how do I think about this? How do I get over my fear? And the midwife did something that I thought was really, really wonderful. So we were all sitting around, just like you are, and she said, "I'm going to teach you how to relax." She said, "First of all, she said, close your eyes if you want to," and you might want to close your eyes. She said, "Close your eyes if you want to," but she said, "Relax your hair." So everybody started thinking about relaxing their hair. And then she said, "All of your stress goes to your jaw." So she said, "Relax your jaw." And then she started talking about breathing and about thinking about your arms and your legs. And as we did that, you could hear little bits of snoring from around the room, but the women were very relaxed. And then she did an exercise that I thought was quite powerful. She gave each one of us a cup filled with ice. And she said, "Pour ice into your palm of your hand." And everybody did, and we sat there, and Nora was, 15 seconds dumping the ice back in. Everybody else went for about 45 seconds, but they were talking about how uncomfortable it was to have the ice burning on their palm. And then the midwife said, "Okay, dry off your hands," and then she said, "Let's breathe, let's relax." And we all poured ice into our hands. The ice totally melted. 3 minutes went by, and not one person dumped the ice out. And Nora said, "I can do it." She said, "I know I can do it." She said, "I can get through my labor." And it was amazing to watch the kinds of care that happen. Centering pregnancy has flipped the meaning of care. What you often find is that when the women go bring their kids into the pediatrician, they're saying, "I don't want to have my one doctor visit. We want all of our babies to be together." So centering pregnancy is now leading to other kinds of improvements in care. But again, coming back to disparities, the thing I love the most is that it's closing the disparities gap. It's reducing the risk of preterm birth by 33%. And it's reducing racial disparities in these kinds of complications. Hispanic women in centering have a lower preterm birth rates than those in traditional models. And the odds of preterm birth in an African American woman is reduced by 41%. Nearly twice the women end up breastfeeding successfully in centering. It's another place where we've got to close the disparity gap, and we can by flipping healthcare. This is the triple aim for birth. It's better health outcomes for the mothers. It's great care. They love being in these visits. And the costs are about $2,000 less per pregnancy when you go through centering pregnancy. So if you look at the 100 approved centering pregnancy sites in the United States today, they could estimate about $44 million in savings. And if we could get everybody to flip to centering pregnancy, there's about $9 billion of healthcare complications and costs that we could eliminate. So these lessons from these 3 people have convinced me that we can go outside like that principal did in his school, and we can think in a very different way. We can flip healthcare. Our theme this year is collective impact. It's how can we do things together? And I love this definition from Bill Shore at Stanford. He says, "Open up your circles. Transformational change requires an organization to look outside its core groups of true believers and to mobilize those less engaged." And I took this photo in Africa. It said, "If you want to go fast, go alone. If you want to go far, go together." So I'm inviting us all together today to flip. Tweet your flips. Let's learn together how we can make changes. I love Stuart Kaufman's Adjacent Possibilities, because as I've talked to some of you about flipping, it sounds like it's a radical change. But Stuart says that you can build on your accumulated knowledge, the wisdom in the room here. The strange and beautiful truth about adjacent possibilities is that the boundaries grow as you explore. So what I'll ask you to do is to step out. As you open up the boundaries, what you find is that adjacent possibilities emerge. And together, we can build a bridge that leads us from where we are today to where we need to go. So in 2014, IHI is going to start building the bridge, and we need you all to join. There are 5 areas that we're going to focus on. The first one is quality, cost, and value. We're going to build strong linkages between cost and quality so that Trevor can stay healthy at college, so we can keep Corolla at home, and we can promise Nora a healthy baby. Together, we can bend the cost curve. And we're going to be working on the triple aim for populations. We're starting with high-risk, high-cost populations, but we're going to be looking at children. How do we make children healthy? How do we begin to move into all of these populations? As Tom Nolan would say, we've learned from the individual, but now we can translate and flip for the populations. We're going to think in a totally new way about patient safety and flip from measuring and responding to predicting and preventing. We're going to move from looking at safety in an ICU or in a hospital setting or in a physician practice to looking at team safety, looking at safety across a continuum. How can we keep our patients safe over the course of a year? And we're going to be building improvement capability. Last year, I looked at how many people came to IHI courses in the United States, and we had about 54,000. And then I looked at how many people work in healthcare in the United States, and that's 11.2 million. That's a gap we need to close. We need to think about new ways to teach and learn, new virtual tools that we'll get out to you so that you can share them with all of your colleagues back at work, because we need to go from 54,000 to 11.2 million, and that's just in the United States. And the Open School is approaching its 1 millionth online course. So I think those students are helping us to flip the way that we think about teaching and learning. And all of this to have higher impact. And then finally, and I think perhaps most important, is person and family-centered care, to flip from what's the matter to what matters to you. Recently, there was I was giving this, talking about what's the matter to what matters to you at a forum in Europe a couple of months ago. And there was a nurse in the audience. Her name is Jen Rogers, and she works at York Hills Pediatric Hospital in Glasgow. Jen went back and said, I can flip things right away. She said, I can do something on my own. And so what Jen did was, when she went back to work, is she changed the policy and gave every kid who was admitted to York Hills Pediatric Hospital a piece of flip chart paper and an art set. And she said, draw a picture, put your name, your first name and your age, and draw a picture about what matters to you. And then they put that on the door. If you come to visit IHI, and I hope you all do, you'll see pictures of these kids, what matters to them, in the office of IHI. But I was particularly taken by one of the stories. It was a young girl, she's 7 years old, and her name is Kendra. And Kendra is severely autistic. So when Jen gave her the piece of paper, she couldn't fill it in herself. But she and her dad, who was her caregiver, sat there and they wrote, Kendra, what matters to me? What you can see is that she was saying, I'm 7, I don't like medication by my mouth, so watch out, I'll struggle with you, it's a 3-person job. She said, I'm very fast, I'll put things in my mouth and I can make a run for it, ha ha ha. She said, I love cuddles to reassure me. And she said, I can dress myself with some help. I can do high fives. She can't speak, but she can do high fives. And what she also said was that the way she greets someone, the way she tells someone that she's affectionate with them is she reaches up and she grabs onto their hair. So Kendra, who can't speak, told us a lot about how she lives by making this poster. What struck me, though, so much was that shortly after her admission, her father collapsed and he was taken in an ambulance to another hospital. If Kendra didn't have this on her wall, you can imagine that the staff would have no way to figure out how to deal with her. They would think that pulling their hair was an assault, not affection. They wouldn't know that she expects 3 people to hold her down to help her take her meds. But because Jen Rogers flipped care and said, "What matters to you, Kendra?" they had this record, and it allowed Kendra to have a wonderful hospitalization. So we've got a lot of work to do in the next year. These are the areas that we're going to be working on. These are the bridges that we're going to build. This is how I hope that we can together cross to have a collective impact in the future. And I know I'm talking a lot about collective impact, but I also want you to think about Jen Rogers, to think about what it means for you as an individual to go back and think about flipping care. So I wanted to read you a story, a quick letter that I got from Gunderson Lutheran. Jeff Thompson, the CEO, sent me this letter recently. And it's about a patient, and it's about a provider who was sitting here in the audience a few years ago when Don Berwick was doing his plenary. The physician writes, "Several years ago, while I was sitting in a large lecture hall," that's here, "Dr. Berwick asked the audience members what we wanted from healthcare and to discuss it with those next to us." Some of you might remember this. After some discussion of high quality, safe, accessible care, he interrupted us and he asked us again, what do we really want from healthcare? More discussion ensued, most of us just reiterating our original points, but with more enthusiasm. He interrupted again and he asked us more emphatically, what do you really, really want from healthcare? Again, more discussion, even more enthusiasm, but at least for me, no new ideas. He then said what he really, really wanted from healthcare was to be able to cross-country ski. And that was very different than the recommendation that his physician had given him, which was joint replacement surgery. So he personalized the issue, and it stuck with this physician at Gunderson Lutheran all these years. He writes the letter and says, "Today, my medical recommendations were trumped by what a patient really, really wanted. I am lucky to care for a 37-year-old never smoker who developed oral tongue cancer. He's had good surgery, good chemotherapy, and good radiation therapy, but the cancer didn't care. We've used the best we have to give him what he needs from healthcare, but his cancer didn't care. It spread to other parts of his body, causing complications and hospitalization. And again, despite more cancer therapy, his cancer progressed." The Friday before Labor Day, a few months ago, will be a day that many of us who cared for this man will never forget. He reported hemoptysis and had a prompt CT scan which showed recurrent cancer in his left lung. Per usual Gunderson service, the scan was done that day and he was seen by pulmonary medicine. Bronchoscopy happened and it confirmed that the patient's cancer had returned. The person who had been with him, supporting him throughout this year-and-a-half medical odyssey, informed us that they were planning to get married in November. And she wondered if this should be moved up. Well, it happened. This morning, while I was reviewing our new cancer treatment plan, or what I thought he wanted from healthcare, the patient's fiance informed me that what my patient really, really wanted was to get married today. Walking back from the CCU, the head and neck nurse navigator and I thought somehow we needed to address this, but it's easier said than done. Because the request is so out of the ordinary, I was reluctant to even ask for help, but asking wasn't necessary. How hard can it be to get married in a hospital? It can be really hard if your marriage license is in a different state. But they figured out that you could get an emergency marriage license if a physician provided appropriate documentation. Pastoral care got involved. We found someone to officiate the ceremony. Flowers appeared, so did a cake. Music was played and sung. Photos were taken. The ceremony was recorded. A hospital room was decorated to look like a wedding suite. A wedding dinner was arranged, and most importantly, a marriage happened. I wish I knew all the people that had made this day happen. I can't even guess the number, 100, maybe more, all of the departments. The patient didn't start his new cancer treatment plan today. That had to wait until what he really, really wanted from healthcare was to be married. So you should know that that's what many of our amazing staff did today. So this is Elvin and his fiancée at their wedding in the hospital. So, as we think about flipping healthcare now, think about Trevor and Corolla. Think about Nora and her baby. Think about Kendra and Elvin. And think about how do we flip care. The challenge I'm putting to you today is great. I'm asking you to think about flipping the balance of care from the hospital to the community. I'm asking for you to think about flipping care from delivery to individual providers and care teams, to flip the balance of power from the provider to the patient and the family, to think about flipping the balance of costs from inpatient care procedures to thinking about co-production. And I'm thinking about flipping the balance of emphasis from volume to value. So we're here together this week. I'm hoping that you'll find inspiration like the physician from Gunderson Lutheran, or like Jen Rogers from Scotland. Find inspiration from talking to all the wonderful patients who are here, or from talking to each other. But we've got a huge amount of work to do. So let's flip. Thank you very much, and have a great forum.